Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bauter and Dan Schwester from the Overrun here. Danny, how we doing?
Oh, doing great, man. Everything's going good today. Not going to snow. I'm really happy because I have to work.
In 12 weeks, we're going to be complaining about how hot it is, too. I can't wait.
Oh,
So,
yeah.
but
Yeah.
speaking of hot topics, today we're going to be talking about a study that came out of Indiana in March of last year. And what they looked at was diagnostic accuracy of pre-hospital lung ultrasound for acute decompensated heart failure. And this was a systemic review and meta-analyses. Devotees of the show will know how I feel about systematic reviews and meta-analyses. They are my favorite. I love 20,000-foot views of what we're doing, right and wrong. And what's interesting about this study, Dan, is we'll get to the data in a second, but even though this is a systematic review and meta-analysis, this was actually more like a feasibility study.
Yeah, I think they're making the case that, point of care ultrasound in the emergency department and especially pre-hospital can be used to accurately give diagnoses of respiratory conditions, which might have an impact on people's morbidity, mortality, length of stay. So there's a lot of potentials here that are really good for medicine. So I was kind of interested to read it and, let's get into the nuts and bolts.
Yeah. So again, they looked at various studies to show the actual use of ultrasound by pre-hospital providers. Now, one of the things that's mentioned in the paper is they did look through a lot of studies, and one of the issues that came up was they were only able to find 8 to really include in the actual analysis. So here you see you have almost 3,500 studies that involve pre-hospital ultrasound. They removed duplicates. They removed a couple different studies here. Some were commentaries. Some had the wrong comparisons. And in here, so the actual amount of studies that were involved in this paper was 8. And there was only about 650 patients among those 8 papers. So I want to talk about that issue first before we really start getting into it, where this is a problem of there's not a lot of data, so it's difficult to analyze everything. But it speaks to the absence of evidence is not evidence of absence. So the first commentary I have is we're not studying this enough, just full stop. And that's something that we need to look more into. But we talked about this a couple of weeks ago, where this demonstrates that you can teach pre-hospital providers to use an ultrasound probe and identify acute decompensated heart failure in the field, which leads to earlier diagnostics, earlier discovery of the symptoms, early discovery of the disease, and theoretically earlier treatment of these patients. So when we talk about how we use ultrasound, and again, I know that ultrasound is kind of this big, hot button thing, right? All the cool kids are using ultrasound now, but this isn't your standard cool kid thing. This is something that has real applicability to pre-hospital medicine, and being able to use them to look at the last study we talked about was to find curly bee lines, right? That's all it was. Can you use an ultrasound probe to discover curly bee lines? All this looked at was, can you use an ultrasound to discover acute decompensated heart failure? And the answer to those things is yes, so far.
Yeah, absolutely. And I think they're step by step. These papers are making the case that point of care ultrasound needs to be out in the field. It needs to be out in our world. It certainly needs to be looked at in the emergency department as much more than what we're using it for now. And I think it's going to have good benefits for patients. But again, if you're a larger EMS agency or you're an educator or something like this, and you're not doing research, you got to start asking your people why. Talk to your medical director, talk to your management team. This stuff is good. It gets your program out there. It's a net positive, but we don't really have any data, and we've got to start making our own data and start understanding what we're doing out there.
Yeah, and in hospital, there's no debate whether or not ultrasound works and is effective, right? I think those horses have kind of left the gate where, in cardiac arrest, ultrasound is used to detect ventricular movement. We've had Devin Dromgoole on several times to talk about ultrasound. I think that's one of those tools where,
we've taken training for ultrasound.
Yeah.
We've actually gone to labs and done these things. And I can tell you, it's not hard to do. It's hard to do well. It's not hard to do at a beginning level, at an initial competency level where the patient can benefit. Am I a fantastic sonographer? No, of course not. But can I find B lines? Yeah.
And that's kind of the key, right? Where we're not trying to train pre-hospital professionals to, residency standards or to fellowship standards. This is using the stethoscope, right? This is using a 12 lead. We're not, and there's plenty of platitudes about like, oh, it's just another tool in your toolbox. But the point is that, okay, while a stethoscope can do 400 things, right? You can identify a million things. Like most paramedics don't listen to heart tones in the field. That's something a stethoscope can do that can lead toward diagnostics. So this is something that you can add to your arsenal where, you have that patient, like right now it's flu season, right? How many patients do you encounter where, your 75-year-old who's got a history that's as long as my arm and they've got junky lung sounds, right? Like the most vague presentation that we can give that always happens during flu season.
Like every other patient today.
Exactly. So with those patients, adding an ultrasound probe while, okay, it's another thing we have to do, blah, blah, blah. You can actually look at it and be like, all right, you know what? That's Ronchi. And I know because as I'm looking at it, I don't see any fluid lines. I don't see curly lines, right? I don't see any signs of heart failure. So now, okay, why is this patient hypertensive? Why do they have these symptoms and all these problems? Because it's not heart failure, right? And I think that as we think about point of care testing, and it's been interesting to watch kind of over the years because when you look at point of care testing, you see, all right, there was resistance to 12 leads. There was resistance to doing blood glucose levels out in the field. And now it's stuff that we just kind of do because we understand its value.
Mm-hmm. Yeah, absolutely. There's always going to be resistance to new things. If you want to have fun, go watch an old episode of ER from 30 years ago. And
Emergency just got put on to Peacock. I don't know if you saw that, but
I didn't see that.
Yeah.
But
watch Johnny and Roy call up for an order to start an IV
with D5W. Like, what? Okay, but everything moves forward, and this is just the next step in diagnostics for us. And I think these studies are actually showing that this is feasible. It's something that we can do. I'm not saying everybody's going to be a master sonographer or we should be doing fat scans in the field, which is we shouldn't. But this stuff is easy. It's very specific. It has a high sensitivity and specificity, and it can make a difference in the treatment of the patient. Because now 6 hours in, after they've been on the COPD pathway, now we have to flip them to a CHF pathway.
Right.
If we just started with the CHF pathway, maybe this person goes to a step-down floor. Maybe this person goes to the floor on a venti mask as opposed to the unit on BiPAP. And with hospitals becoming more and more crowded, more and more high acuity patients presenting and boarding happening in the ER on a regular basis, we should be having these diagnoses are easy. They're the ones we should be hitting out of the park because it's going to be better for the patient. It's going to be better for the system.
And again, thinking about the applicability of it, where there's so many patients that give this kind of vague presentation, right? Yeah. Where it might just be, or think about how many failure patients have you had that have gotten nebulizer treatments, albuterol treatments before you get to them, right? So how effective would this be in those patients where you're like, man, their blood pressure sitting at like 160/90, and they're like, is that a CHF hypertension? Is that just their presentation, right? This is something where, all right, you know what? I'm going to take out my ultrasound probe. I got 30 seconds, bam, bam, checked out. All right, I don't see any fluid. I don't see any curly lines. Let's go ahead and go down the COPD route, right? And as opposed to flooding these patients with their own pulmonary edema so that we can go, turns out it's actually fluid. And then now we're so much further behind the 8 ball of treatment. So, and again, this is a meta-analysis. It ends up with a small n, which is, it's a flag that you want to throw up, right? You always want to say, all right, there's more research, there's more data that can be done on this. But, okay, can we have providers learn this one very specific skill to change diagnostics? Because you have to start somewhere. So far, what we've seen seems to say yes. I don't think there's a debate anymore as to whether or not point of care ultrasound has a place in EMS. I think now it becomes more of a conversation of will. Or of will and ability, I guess I should say.
Where now, that's right. Really what we're looking at.
And we're starting to find, all right, we have the ability. Now we just have to decide, all right, we're going to do it and figure it all out. But let us know what you guys think. Are we using point of care ultrasound in the field, and how do you like it? Be sure to check out all of our stuff on EMS One. We have a whole bunch of news stories that come out every month over there, and listen to the podcast on YouTube and Spotify and Apple Music. For the Monday Afternoon Journal Club, I'm Ed Bauter. He's Dan Schwester, and we'll talk to you next week.